three siblings can have different presentation of epilepsy, though they have the exact same gene mutation. One may have more severe epilepsy, one might present earlier, one might have other comorbidities which are having a bigger impact.
Fellow Homo sapiens, now we all know that our diets are pretty important, right? But did you know that there is a genetic epilepsy called GLUT1 that messes up the absorption of the glucose that we have to our brains and causes seizures? Well, this week, consultant neurologist Kathleen Gorman tells us all about her work in neurogenetics of the genetic epilepsies and specifically the rare epilepsy GLUT1 Deficiency Disorder.
My name is Kathleen Gorman. I am a consultant paediatric neurologist in Children's Health Ireland at Tampa Street, which is located in Dublin, Ireland. And I am a paediatric neurologist who looks after all neurological conditions, but especially epilepsy, movement disorders, and neurogenetics.
Tell us a bit about the neurogenetics, because not everybody is familiar with that term.
It's really been exploding speciality over the last 10, 15 years. And what we mean by neurogenetics is really genetics got to do with brain. So whether it is related to epilepsy, movement disorders, migraine, or neurodegenerative conditions, is really focusing on genetics related to neurology.
All of the aforementioned are frequently interlinked, right?
Absolutely. And I think we're realizing more and more how important genetics is. And I think you're realizing that, with your podcast and everything, about how important genetics is, not just with neurology, but with all conditions. And I think it's exploded over the last 15 years. And we've learned so much, but there's still lots to understand. And I think that's what will kind of grow over the next few years, that if we understand the genetics, then we can then focus our treatments and hopefully have better treatment options and cures for many conditions we don't have anything to offer at the moment.
And just to reassure everybody, it's not like the number of people affected by these conditions or diseases has increased, right? It's more that we're actually recognising them more.
Absolutely. That's completely it. It's just that, say, if you came to see me 20 years ago, that my predecessor would be able to say, we know that your epilepsy is likely something genetic, but I don't know what it is. And just now we have the technology and the ability to say, well, actually, it's due to this gene or that gene, or sometimes we don't know still. But it's not that it's gotten more common. It's just that we now know how to find it.
And so are you involved in whole exome sequencing or whole genome sequencing with your patients?
We have two different aspects. So I guess in the clinical setting, we have whole exome sequencing. And I don't know if you want what whole exome sequencing, I'll just say very quickly, is when we look at about 2% of your genetic material, but we know about 95% of diseases are from there. So that's why we focus on that part of your genetic code, because we know that's where most of our changes in our genetic code are. So in the clinical setting, that's what we offer patients. And we're very lucky in Ireland. We're a little bit different to the other, say, the NHS, that we have very good access. Our clinical setting, we have very good access to genetic testing. And then in whole genome sequencing, it's just in the research setting at the moment. And that means we look at all your genetic material. And that's what's been offered in the NHS now. So we're a little bit behind in Ireland compared to the NHS in that part.
And when you do this genetic testing, are you doing it solely on the patients, or are you doing it on the mums and dads, biological mums and dads as well?
It depends. So depending on the child. So usually I will start with the child. And the reason why I do that is I will start with a thing called genetic panel, which looks at maybe 100 genes related to, I'm going to focus on epilepsy, related to epilepsy. And the reason why we do that is because it just makes the analysis easier. We know that most genetic epilepsies are caused by a handful of genes. But if we don't find a cause, or if it's a different presentation, then I'll extend the analysis and include the parents as well. So each situation, we kind of evaluate each case by case.
Would you say most of the genes responsible for the genetic epilepsies tend to be de novo mutations, or would you say most of them are inherited, if one can answer that question?
So I think it depends on what kind of case you're looking at. So I think if you look at the children, and I often will talk about children because it's what I look after. But if we look at the children who present in the first 2 years of life with the really severe or early onset epilepsies, I would say the majority of those are de novo, but definitely there are some inherited. And so it depends on the gene It often depends on the family history, and that'll kind of give us an idea about what the inheritance is. And then if kids who are presenting older, some will be de novo, or something new in the child. Some might be that there's a relevant family history. So maybe the mum had or dad had febrile seizures, and they can have a different presentation of the same gene. So sometimes it can be a different presentation, even though you've got the same genetic change.
That's really interesting, actually, because I think commonly believed is that if you have the same genetic mutation, whatever that might be, then you are going to have the same symptoms, or that it will present itself in exactly the same way. But as you've just implied, that is certainly not always the case.
Definitely not. And I think the more we're learning about genetics, the more we're realizing that. So, and we definitely are seeing that more, even more. I think especially in epilepsy genes, we're realizing that the same family can have 3 different presentations of epilepsy, though 3, say, siblings can have different presentations of epilepsy, though they have the exact same gene mutation. One may have more severe epilepsy, one might present earlier, one might have other comorbidities which are having a bigger impact, with learning problems, even though they all have the same gene change. So there's something else we don't understand without a doubt. And I think we're still learning. And that's the big thing to understand, is that we're still trying to understand, and we don't know everything.
Yeah, right. And as I said in many podcasts, the more you learn, the more you realize you don't know.
Absolutely. And I think that's the important thing, to realize there's so much we just don't know, and we need to learn more.
One example of a genetic epilepsy would be GLUT1. Upcoming is GLUT1, is it International GLUT1 Awareness Day? I'm sure I said it the wrong way, but could you tell us about GLUT1 and people or children that you help who are affected by this genetic epilepsy?
For people who don't know what GLUT1 is, it is an example of a genetic epilepsy, exactly like you said. And it's due to a change in a gene called SLC2A1. And what this gene is really important for is that it is about transporting the glucose in your blood across to your brain. So when you have a change in this gene, you can't get the glucose as your energy. Your glucose gives you the energy to do everything. It doesn't pass into your brain. And so children have different presentations. So it's really interesting because things are really broadening how children present. So children can present with early onset epilepsy, so epilepsy in the first 2 years of life. You present with absence seizures, so really severe absence epilepsy. You could just present with generalized epilepsy. Other children might present with learning problems. Movement disorders is what I will see. So movement disorders related to after exercise, because you need that energy. And I suppose the reason why we think about this epilepsy is because we treat it differently. When we have this genetic change, we know that we treat you with a ketogenic diet, because that is a different way of providing you with that energy. So it's something that if we get that genetic cause, we adapt your treatment. And that's why we always want to think about it, because we have different options treatment-wise.
When I first heard about GLUT1, it made me think of types of diabetes where people struggle to, or can struggle to, have their blood sugar at a sort of stabilize their blood sugar and can go up and down. I know this is a completely different condition, but would you say it has any similarities?
So I suppose it's a little bit different in that you have too high sugar in diabetes. So by this one, you have low sugar. I suppose it is all about how you transport your glucose and how you metabolize your glucose. So it's still focusing on that glucose. It's just that usually your glucose is too low in your brain. So your glucose is fine in your blood, but actually it's in your brain that it is low. And that's why you need other sources of energy through the ketogenic diet to kind of provide that energy source.
And does the ketogenic diet sort of stabilize that blood sugar for the people affected?
Yes, it's trying to provide a different source of energy. So it's trying to bypass that faulty change that you have in that gene or that transport mechanism, and using your ketones as an alternative source of energy. So it's trying to find give your brain that extra source of energy to be able to kind of to work properly.
Just to let everybody listening know that the ketogenic diet actually is not the same as the Atkins diet. It's pretty severe and full on. Well, actually, I know a family who do use it, or their son uses it, and it actually for them provides, well, it's an amazing sort of management tool for the seizures. Does it work for everybody?
Like you said, we use the ketogenic diet in different things. So we use it in GLUT1. We the majority of children will respond to it very well and be able to come off their anti-epileptic medications. But we also use the ketogenic diet in children who have severe epilepsy and adults who have, epilepsies not responding to other treatments. We're now using it very much earlier in infantile spasms because we realize that if your medications aren't working, then we should be using this earlier. So we're now using it earlier and earlier. What do I know? I can't tell you the exact percentages, but does it work for everyone? No. But in GLUT1, it works for the majority of people. Just saying about the ketogenic diet, there is other options.
I read one piece about the ketogenic diet for people with GLUT1, and I heard that it can not solely improve management of seizures, but actually can positively affect their cognitive function as well. Does that often happen?
So definitely in GLUT1, it definitely helps, because I think if you think about it, when we are hungry, that's how I think about it, that I can't function properly and I get angry and I am sluggish. So I think of GLUT1 exactly like that your brain just is not having enough energy. So often parents will say that, once they eat in the morning time, they're brighter. That the morning time is terrible because you've been fasting for a few hours and you'll be really annoyed. So like that, it's because your energy, because your head. And absolutely, parents will say on the ketogenic diet with GLUT1 that they're brighter, they're learning more, that they're able to interact better. And some parents will even say that for kids who were using it in other options, for other severe epilepsies, that maybe it hasn't had the most amazing effect on their seizures, but actually they're brighter, they're more interactive, which is actually really important as a quality of life measure. If you're able to interact more with your siblings, if you're able to enjoy school better, that is really, another positive outcome that you can have. And some parents will say that it did minimal stuff for the seizures, but actually they're brighter, which is always a good outcome.
Also, I suppose, would this minimise the child's risk of SUDEP as well, sudden unexpected death in epilepsy?
If you can reduce the seizure burden, that's always going to have a positive effect. We know that for SUDEP, that the longer duration your seizures, if you've the older you are, if you have the more severe seizures, if they're happening in nighttime, they're always the biggest kind of risk factors when I'm trying to think of the people who I need to have the discussion with, or to remind myself to discuss it with parents. And they're always the things they're kind of the four things I think about. So if you have an overall benefit on seizure reduction, then absolutely that's going to have another, a knock-on effect improvement on the SUDEP risk.
Yeah, and imagine once you are able to help a child sort of more effectively manage their seizures, then potentially you've sort of got more time, and the kid and the family have got more energy to also focus on common comorbidities as well. You mentioned those briefly.
Absolutely. I think, for the start, in the first few months and years, I see this in epilepsy and movement disorders, that we're very focused on treating the seizures and treating the movement disorder, or trying to focus on that. But we often forget about the other stuff that, like you said, can have such a big impact, and so I think, sometimes schooling, that, as you're getting older, that your needs get bigger, that what you have to do gets bigger. It's not that your learning has gone down, it's just that you're now more is expected of you. So I think that's always a big focus, especially when we transition to primary to secondary school, is I think where most people notice it, because you need to do more. And I think the other big thing that we're realizing is the associated mood disturbances that people have, and anxiety, and the kind of concentration issues, and whether the anxiety is related to having epilepsy, or related to the meds, or related to your underlying gene condition. I think it's a combination of all three that we often don't focus on that, because we're so focused on treating seizures, and not looking, at the other aspects.
It's about quality of life for the patient and the family. It's not solely about seizures, but especially in things like GLUT1, initially, understandably, seizures can be a priority in management of those seizures. To learn more about Kathleen, make sure that you check her out at torierobinson.com/epilepsy-sparks-insights, where you can find out more about her and links to her work. Also, if you enjoyed this episode, please do share it with your friends, family and colleagues, because it really helps us to get the messages about the epilepsies out to the masses.